Hi everybody, I think we might make a start. I think we'll be recording this session, so hopefully everybody can hear me okay in the room and online. So this session today is all about chamber assessment, and actually whilst it sounds quite generic, I think that is the one thing that everybody really wants to know, and it's really going to affect everybody's everyday practice. So these are really important topics here, and we've got some brilliant speakers today. So I'm Rhea Payton, I'm a clinical academic from Leeds, and I've got Evie here.
Hi, I'm Evie, I'm at St George's, and I'm a clinical scientist.
So we're going to chair the session. We just take this chance just to remind you to pop any questions in Slido. And depending on how the presentations go, we might ask questions at the end, but we'll keep an eye on everything. So please use Slido and download that so that you can ask any questions through there. So first up, we have Wendy Gamlin, who we've all already heard from today, but I'm sure she's got some great things to share. She's got my favourite topic, which is the assessment of the left ventricle. Wendy's the non-invasive lead at Manchester Royal Infirmary, and she's got lots of experience and also teaches through the STP at Manchester. So I'm sure she's very used to talking on this subject, and I'm sure she'll have some great things to share with us today.
Thanks very much. Welcome everyone, and thank you very much for coming along to this session. Firstly, just to thank the organisers for letting me talk to you today. I've got no conflict of interest. So we've got quite a lot to cover in this session. It is a bit of a whistle-stop tour, so intend to cover a bit of gross anatomy of the left ventricle, assessment of size, assessment of function, emphasis completely on systolic function. I'm not going to mention diastolic function, that's a talk in itself. And then I'll just finish with a couple of slides just to highlight some other considerations when we're thinking about assessment of the left ventricle. Okay, so just starting off with a little bit of anatomy. So the left ventricle is a conical, smooth-walled structure. It's got a broad base and a narrow apex, and the thick muscular walls, and they narrow towards the apex. The septum is curved, meaning that the left ventricle appears circular in cross-sectional imaging. It's got an inlet, outlet, and apical portion. The inlet portion contains the mitral valve and the subvalvular apparatus, and the outlet portion supports the aortic valve with fibrous continuity between the aortic and mitral valves. The apical portion includes fine trabeculations, but you may also see some false tendons and muscle bundles down there as well. There's usually two papillary muscles, the anterolateral and the posteromedial, and these attach to the cordia, which obviously then insert into the mitral valve leaflets. So the left ventricular myocardium is made up of three distinct layers of muscle. So we've got longitudinal muscle fibres. These are the thinnest layer. They account for less than 20% of the overall wall thickness. They're deep subendocardial strands, and they run the long axis of the ventricle. They're responsible for the movement of the base towards the apex in systole. So the radial fibres are the thickest layer. They account for between 50 and 60% of myocardial thickness, and they run parallel to the mitral valve orifice. And it's these strands that when the heart contracts, they compress into the end of the cavity and affect the radial contraction of the left ventricle. Circumferential fibres are superficial. They account for about 25% of the thickness of the myocardium, and they're organised at around 10 to 20 degrees angle from the long axis of the heart. And it's these fibres that cause the twisting motion of the heart during systole. So from an echo perspective, we begin our assessment of the left ventricle in the parasternal long axis view. And in this view, we can see the basal and mid segment, of the interventricular septum and the infralateral or posterior walls. And here we can make a visual assessment of the motion and radial function of those walls. It's a little bit of a mixture on the slide. Some normal function, some really quite terrible function, and I think some regional wall motion abnormalities as well. And it's in this view that we'll also measure our left ventricular dimensions and wall thicknesses, both at end systole and end diastole. So historically, we made those measurements using M-mode, and that utilises the transmission and reception of the ultrasound beam along a single scan line to produce a graph of depth and strength over time. So we placed our cursor just beyond the tips of the mitral valve leaflets. It needs to be perpendicular to the left ventricle, and the chamber size and wall thicknesses were measured during end diastole and end systole, and we measure in M-mode from leading edge to leading edge, so a bit different than the 2D measurements that we tend to make today. If you can't get the cursor perpendicular to the left ventricle due to an off-axis image, then you're going to overestimate the wall thicknesses and the chamber dimensions, and consequently, BSE discourages the routine use of M-mode for the measurement of LV dimensions. It's acceptable if you can get a good on-axis image, but otherwise, don't bother. So moving on to 2D. So we make our 2D measurements of the ventricle instead. Again, perpendicular to the long axis of the ventricle. We're going to measure at end diastole, and we can define this as the frame before the mitral valve closes. Surrogates for this include the onset of the R wave, or sometimes the frame with the largest cavity diameter. We need to measure compacted myocardium only, so that means we have to avoid any trabeculations, any subvalvular chords or moderator band in the right ventricle, because sometimes you can see that in parasternal long axis. Worth remembering that we're using 2 dimensions to measure a 3D structure, so the measurements in any of the parameters which we then go on to derive from them are relying on the assumption that the left ventricle is a particular shape with a symmetrical distribution of wall thickness. So as soon as you've got any regional wall motion abnormality or any asymmetric pattern of hypertrophy, then the 2D measurements, the 2D dimensions, will correlate less well with the actual ventricular size. So moving on to end systole. So that's defined as the frame where the aortic valve closes, which is fine in your parasternal long axis view because you can see the aortic valve. If you're in an apical view and you can't see the aortic valve, then you can use the frame prior to the mitral valve opening and make any measurements there. That's end systole then. We're going to make our measurement end systole in the same plane as you took your diastolic measurements. Again, measuring compacted myocardium only and taking care to avoid those trabeculations and chordae from the mitral valve. So on the slide, just for your reference, I've popped the reference ranges. You'll note that we grade the dimensions from normal to severe and correct them for gender, but we don't index to body surface area for dimensions. So let's think about some of the values which are derived from our dimension measurements, in particular our wall thickness measurements. So we can think about relative wall thickness and LV mass. And it's important to remember that simply having increased wall thicknesses doesn't define your patient as having left ventricular hypertrophy. Instead, this is determined by having an abnormal indexed LV mass. So LV mass is calculated in a parasternal long axis view using the cube formula. I've left the equation on the slide. Thankfully, your echo machine will do it for you. And if you've entered the patient's height and weight before you started scanning, it also indexes the measurements for you as well. Wall thickness and diastolic dimensions are used to calculate relative wall thickness. And again, I've popped the equation on the slide for that. Again, your echo machine will do it for you. Don't forget that if there's a basal septal bulge, that's going to overestimate your LV mass. So it's important in the case of having a basal septal bulge to make that septal wall thickness measurement distal or more apical than the bulge. So we can now use our indexed LV mass and the relative wall thickness to define our patient's left ventricular geometry. So if we were to plug in the values from the previous slide, the patient had a relative wall thickness of 0.8 and an LV mass indexed at 128.04 grams per metre squared. So that, if you look at the diagram on the right-hand side of the slide, describes the patient then as having concentric hypertrophy. It's important to note that describing the geometry as concentric hypertrophy is not saying that we've got uniform thickening of the muscle. You can have a patient with focal thickening, and that could still work out from these measurements to be concentric hypertrophy, just as you could have uniform thickening and a pattern of eccentric hypertrophy. I've popped the ranges on the slide again. We don't any longer categorise the wall thicknesses as mild, moderate or severe. There were very small measurements and differences between the measurements anyway, so we can't really be that accurate. But they are corrected for gender, as is the LV mass, and indexed to body surface area. So a quick note about a couple of other values that you'll see on your slide when you measure your LV dimensions. And basically, we probably want you to ignore them, but it is useful to know where they come from. So both fractional shortening and the T-Coates ejection fraction are derived from ventricular dimensions, and both basically just describe systolic function at the base of the left ventricle. So fractional shortening reflects the percentage change in ventricular dimensions, and T-Coates ejection fraction reflects the percentage change in volume, with those volumes being derived by cubing those dimensions. So both parameters reflect function in a normally shaped ventricle with uniform function. So again, any regional wall motion abnormalities outside of those walls will overestimate the systolic function. So don't use them. Just useful to know what they are on the slide when you see them. Moving on from parasternal long axis, we continue our assessment of the left ventricle and the parasternal short axis views, where we can visually assess the radial function of the base, the mid and the apical levels of all walls of the left ventricle. We can also make wall thickness measurements, which might be required if we were following the hypertrophic cardiomyopathy data set in the clock phase. So onto the apical window. From the apical forechamber, we can see the whole of the septum and the lateral walls. From the two-chamber, the inferior and the anterior walls. And from the three-chamber, the anteroseptum and infralateral walls. We need to take care not to foreshorten the LV cavity. So the three to the right of the slide, nice, good on-axis images. If you look at the four-chamber view at the bottom left, you can see that the apex looks like it almost contracts down into the cavity. That's because we foreshortened the image. Probably need to drop down maybe a half a rib space or even a rib space to try and improve that. So it's really important to optimize the images to focus on the left ventricle, so decrease the depth and narrow the sector. There's also a button on some machines called virtual apex, and that widens the top of your sector. Can be particularly helpful if the LV is globular and remodeled and you can't quite fit it all in to a nice narrow sector. And it's from using these focus views that we'll go on to derive our LV volumes and ejection fraction with Simpson's biplane. So we measure Simpson's biplane by tracing the endocardial border in both the apical 4 and the apical 2-chamber views. And we're going to divide by doing that, we're going to divide the LV cavity into multiple slices with discs of a known thickness and diameter. And the total volume of the cavity then is the sum of all the discs. The end diastolic and the end systolic volumes can then be used to calculate the ejection fraction. The formula's on the slide there for you. Now, this is a measurement we should be making in everybody as best as we can, as best as our image quality allows. You need to be able to see the about 80% of the endocardial border, and you need to be able to see it throughout the cardiac cycle to ensure that you can get some degree of accuracy in your symptoms biplane. If you can't see more than 2 segments of the myocardium, then don't measure it, because you're just making it up, basically. And again, if your images are foreshortened, try and modify your window. If you can't modify your window, don't measure it. So Simpson's is particularly helpful in the presence of regional wall motion abnormalities, and also in things like if the patient's being considered for an ICD and we really need to know what the ejection fraction is, or your other group of people is your cardio-oncology patients on Herceptin surveillance monitoring, looking for small changes in ejection fraction. It's quite a time-consuming thing to do, and like anything, you need quite a bit of practice. You do get quicker with practice. Some people wait till the end of the study to do the actual trace. I would recommend, if you're going to do that, freeze and scroll through your loop, because what looked like you could see it fine whilst it was moving, when you actually scroll to the frame you want to measure, it's not always as clear as you first thought it to be. So either do it during the scan or make sure that you can actually see the bit that you want to measure. Also be aware that as we're only using the 4-chamber and the 2-chamber view, it's again possible to overestimate the ejection fraction. So if you had an infralateral infarction, we're not even including that wall in our assessment, so you're going to overestimate the function there. So let's look at it with a couple of actual proper echo images. So again, we've optimised and focused on the LV to get the best endocardial definition that we can, and we've traced around that endocardial border at end diastole and end systole. The length is the distance between the most distal point of the LV apex to the midpoint of the mitral valve level. Again, make sure the ventricle isn't foreshortened. Papillary muscles and trabeculations are part of the chamber, so just take care to trace behind them. Don't include them in your border. I hope you'll agree with the measurement on the slide. So the volume measurements that we get from the Simpson's measurements are indexed to body surface area. Just look at that in the 2-chamber view for the same heart. Again, hopefully you will agree. I think we got an ejection fraction in the end of about 58% with this patient, which is probably fair. So if you can't see the endocardial border particularly well, but your patient is an oncology patient or is a patient being considered for an ICD, then it might be useful to use contrast to help visualize the endocardium border better. So a contrast agent is basically microbubbles with a sulfur gas core and a phospholipid shell, and they're very small, 1 to 4 micrometers across, which means that they're small enough to pass through the pulmonary circulation. Once you've got your contrast enhanced images, then you can make your Simpsons biplane measurements as you normally would. Just be aware that the volumes that you get will tend to be a bit closer to CMR volumes than the normal echo volumes. They're greater than your usual biplane from a 2D image. Contrast itself is quite a skill, using a contrast for an echo to make sure that you've not got artifacts and things like that. In our centre, we tend to use the physiologists who perform stress echo and are used to using contrast will do most of the contrast studies. The other thing just to note that you can use contrast for is to rule in or out the presence of thrombus, which you can see quite nicely in the apex on the bottom slide. So we said that Simpsons was time consuming, and while we do need to learn how to do it properly ourselves and manually, it's good to note that the AI in echo is always improving. Some of these semi-automated measurements can be a useful addition to your clinical practice. If the image quality is good, you can see that it tracks well. This takes probably about a minute and a half or something, if that, to actually run and do an EF for you. And if the image quality is good and your practice ejection fraction is good, then you probably get similar values within around about 5% between this and what you can trace yourself. So it might be helpful just as a backup. If you've got an opinion on what you think it's going to be, it might be a good backup for you to use. And just a quick slide just with the normal ranges on again. So we should include an estimate of left ventricular ejection fraction in all of our echo reports, ideally with Simpsons biplane, but obviously if the image quality is suboptimal, then we can give a visual assessment. Usually try and give a range of about 5% if you're going to give a visual assessment. So we talked a little bit about the limitations of Simpsons biplane in that we couldn't take into account regional wall motion abnormalities in the 3-chamber view. And we talked a little bit about potentially not being able to measure it if the ventricle was foreshortened. So just a very quick slide to say that if you are able to obtain a 3D data set, you'll need really beautiful images with the patient and decent stable heart rate and decent sort of ability to pause respiration potentially as well. But if you can get a 3D full volume data set, then that removes some of the issues with the apical 3-chamber view and also with the foreshortening, and you can get a nice 3D assessment of ejection fraction. Again, it's a semi-automated measurement, so that makes it really quite reproducible as well between operators. Have a go. So we've talked a little bit about ejection fraction and global assessment, therefore, of left ventricular function. So let's think a little bit about regional assessment. So to allow regional assessment of the left ventricle, the heart's divided up into 16 or 17 segments. So each wall's basically broken down into 3 segments, the basal, mid and apical regions, and then if you use a 17-segment model, it's the apical cap that is your 17th segment. So each segment relates to specific coronary artery territories. So you've got 2 coronary arteries, as I'm sure you're all aware, the left and the right. The left coronary artery consists of a short main stem which quickly branches into the LAD, the left anterior descending, and the left circumflex arteries. So the LAD supplies blood to the anterior wall, the apex, and the anterior 2/3 of the ventricular septum. The circumflex artery the circumflex artery supplies the lateral wall, and in a small percentage of patients it will also give rise to posterior descending artery. The right coronary artery in most patients supplies both the sinoatrial and the atrioventricular nodes, the anterior RV wall, and it gives rise to the posterior descending artery supplying the inferior wall of the left ventricle and the infraseptum. And this is a really nice diagram which I pinched from my head of training, which demonstrates that 17-segment model on the coronary arteries by colour code, which is really nice as a learning tool. So probably helpful just to mention briefly the terms that we use to describe systolic motion. So on the slide, I hope you'll agree, the top left-hand corner is normal systolic functioning, normal thickening. Bottom left, I hope you'll agree that the inferior wall in this looks hypokinetic, so there's less than 50% thickening. Top right of the slide, hopefully in this one you'll agree that the inferior wall is entirely akinetic. It's not thickening or moving at all. And in the bottom right-hand slide, the septum is dyskinetic, so it's moving in the wrong direction. So let's just work through an example for an assessment of regional wall motion abnormality. So we're starting the parasternal long axis view. And thinking about our coronary territories, hopefully you'll agree with me that the infralateral wall, basal to mid-infralateral wall, looks pretty normal in terms of function. The basal anteroseptum is at best probably hypokinetic. The rest of the anteroseptum, I think, probably looks akinetic. It's not thickening at all. Coronary territories for that then would be the LAD territory looks akinetic. Circumflex territory so far looks normal. So moving on, the same heart and short axis, and hopefully again you'll agree that the basal anteroseptum appears to be akinetic. Basal infraseptum probably hypokinetic. The other walls at the base appear to contract really quite well, probably normal function, but as we go down through the mid section and then right the way down to the apex on the very far right of the slide, there are more and more regions of akinesis until really only the infralateral and lateral walls retain much contractility whatsoever. Down at the apex, nothing much is contracting. So again, moving on to the four-chamber view, same heart. I think the basal infraseptum is at best probably hypokinetic. The mid to apical infraseptum all look akinetic, so they're not thickening at all. I think the basal to mid lateral wall segments look normal, and the apical lateral wall segment I think is also akinetic. So again, if we're thinking about our territories, we've got some issue in the LAD territory, maybe some of the RCA involvement as well, but the circumflex territory is still looking quite normal. I thought it wasn't going to play there. Quite difficult to do regional wall motion abnormality if the slide doesn't play. And the apical two-chamber view, I think that the mid to apical inferior and mid to apical anterior walls, hopefully you will agree, look akinetic. Basal inferior is probably normal, and basal anterior maybe a little bit of hypokinetic. So again, we're thinking about the LAD territory and also a bit of RCA territory as well. And so moving on to the three-chamber view, she says, hoping that they are actually going to play. Maybe, maybe not. You might have to take my word for it, since it seemed to be a frozen. So basically, in this view, if it would play, let me see if we can click on it and make it play. It was playing this morning. So basically, in this view, the whole of the anteroseptum, to me, looks akinetic. You may well have to take my word for it. And basal and mid infralateral looked okay in this view. Is it going? No. Let's move on. We've seen it sort of in the parasternal long axis anyway. It just suffice to say that once we get down to the apex, that those segments don't work either. So it's likely then that the patient's had an extensive LAD infarct and perhaps some RCA involvement as well. But circumflex territory, I think you'll agree, looked fine throughout. So we have talked about global assessment of systolic function, and we've talked about regional assessment of systolic function, thinking mainly about the radial function. So a quick slide now about longitudinal function of the left ventricle, so the shortening of the chamber from the base to the apex. And we can measure this using tissue Doppler velocities. The ultrasound beam needs to be parallel to long axis function. It's quite easy to do for your infraseptum, because it's usually straight down the middle of your sector, hopefully, but you might need to modify your view slightly to be straight to get perpendicular for your lateral wall. You need a high frame rate to obtain your TDIs, so make sure that you reduce your sector width and depth to optimize your image appropriately. And we're going to measure in this view the systolic or S wave. And we just need to take care not to mistake it for the isovolumic contraction, which is the first little deflection that you see. So make sure it's the second deflection that you see that you measure. In this view, we can also measure our E and A prime values, and we use these along with the transmitral E and A waves, LA volumes and TR velocity to make an assessment of diastolic function, completely outside of the realms of this talk, so we're not going to mention that today. I've just popped the normal S-wave values on the slide for you, and you can see that they are corrected for age. So one of the disadvantages of using tissue motion or velocity as a measure of function is that all of the myocardium is stuck together and it's all interconnected. So basically, function in one area affects function in another area. So TDI can't tell you whether or not that wall is moving because it's contracting or it's moving, it's actually necrotic and it's being pulled by another interconnected segment. So that is going to bring us nicely onto our next slide, which touches on speckle tracking and myocardial deformation. So instead of looking at motion, we can look at how we can look instead and measure how much the tissue deforms. How much does it shorten during systole and lengthen during diastole? Necrotic myocardium doesn't deform, regardless of the behaviour of the surrounding healthy tissue. So if we measure strain, then we can get a better idea of what's actually working against what's not. So we can measure strain in all of the directions that those myocardial fibres run in. So in the radial, the circumferential and the longitudinal planes, we can do that. So in clinical practice, we measure global longitudinal strain, and we do that using speckle tracking. So the software on our machines chooses some speckles in the myocardium and basically tracks them all the way through the cardiac cycle and determines basically the percentage change in length as they do that. We obtain our average peak global longitudinal strain using apical long axis view, apical 4-chamber and apical 2-chamber views, which you can see on the slides there. The process is quite automated on some machines, semi-automated on others. If you have to make any measurements, any adjustments, basically you probably have to pick the basal segments, and the apical segment is usually the most that you have to do with your machine, and the machine will then track the endocardial border after that. It's really important that it's tracking well. You need a good ECG trace for triggering and high image quality. If you couldn't measure a Simpson's biplane, you probably can't do strain either. So make sure you do have good endocardial border. Your frame rate really needs to be between 40 and 90 frames per second, higher if the patient's tachycardic. So the machine will provide you, if you can see, a strain curve, and you'll also get the video, which for some reason is not playing at all, which shows you it tracking. And you can see the slide on the bottom of the slide, bottom left. Then you can also see the individual segments. If the machine thinks it can't see one, it will be greyed out. If you think it is tracking it fine, you can add it back in. Or if you think there's an area that isn't tracking properly, you can also click on it and cross it out. If you have to exclude more than 2 segments, then it's not tracking adequately and you shouldn't go ahead and track on strain. Once you're happy that everything's working well and you can accept it, then the machine will provide you with a bullseye plot and an average measurement of strain, as well as a measurement of strain in each plane. If you're new to measuring strain, it's helpful for yourself probably, but also for those people that are trying to help to educate you. If you don't just keep the bullseye at the end, if you just actually acquire all 3 images as you go along, and then if somebody disagrees, at least it can give you some pointers on what they disagree on. So normal values for strain are between -18 and -22. They're negative values because the myocardium should shorten during diastole. In terms of colours, red is negative strain and dark red is better than light red. Positive strains are strain that's, when it's doing the opposite of what it should be, is blue. Now, strain values will differ depending on the vendor of the echo machine. So serial measurements should be performed on the same machine, ideally, especially in those patients where it's really quite an important measurement. We can use strain to highlight subclinical changes in LV systolic function well before there's a measurable reduction in ejection fraction, so it makes it a very useful tool in cardio-oncology when you really do need to spot those deteriorations in LV function in order to start some treatment before you have to stop your cardiotoxic drugs. So always measure strain in those patients if at all possible. It is also useful in other diseases, so processes obviously including HFpEF, so heart failure with preserved ejection fraction. Regional wall motion abnormalities is helpful in, as are cardiomyopathies, and there's a couple of different strain patterns that you can see on the slide there. So, oh, these are playing again now, that's good. So, last couple of slides, just a couple of other considerations to think about while we're assessing the left ventricle. It's really important to rule out the complications of an MI. So thrombus formation isn't uncommon, especially in the presence of apical akinesia. Sometimes it's quite obvious, the top left-hand picture, it's pretty obvious, but there is actually thrombus in the bottom left as well. It's just more laminar thrombus. Use contrast if necessary. Also look out for post-infarct VSDs. You'll have to search quite hard, depends which wall, so which view you're going to see it in. I think it's pretty obvious in the middle slide. About midway down the septum, you can see a little area where it's a little bit deficient in tissue, and the slide underneath with a colour shows a VSD. The patient doesn't necessarily need to be really poorly. Sometimes they're quite stable, so just because they're stable doesn't mean there isn't one. Look out for pseudoaneurysms and aneurysms. So the top right-hand slide is a pseudoaneurysm in the infralateral wall. You can see quite a narrow neck. It's contained by the pericardium, and there's actually quite a lot of thrombus formation in that pseudoaneurysm as well. It's important to spot it because it's treated fairly urgently with surgical repair. The patient is fine, that one. Also consider that if you've got acute severe MR, that might indicate papillary muscle rupture. So if your ventricle is quite hyperdynamic and all of a sudden the patient has a lot of MR, then that is a possibility. And last but not least, we can't assess the LV function, the LV full stop, in isolation. So do consider the impact of coexisting valvular heart disease, such as severe AR or MR, on left ventricular function. Also consider cardiomyopathies and infiltrative diseases. The top right-hand slide is a patient with amyloid, so the myocardium is quite speckly. And also remember, it's supposed to be a smooth wall structure. So if you look at the bottom slide, you can see that it looks very, very tuberculated towards the apex in that. And it's actually a case of non-compaction, a rare congenital cardiomyopathy. So not sufficient just to comment on literally size and function, just also have a look at it, make sure it looks how we would expect it to be. We'll finish there. Thank you very much.
Wendy, thank you. That was brilliant, and you can see how big a crowd you've drawn from that lecture. And it was a complete whistle-stop tour because it's really hard to squeeze everything in 30 minutes, but you did so well. Thank you.
So because of time, I think we've got probably time for one or two questions. So we've had one come in that says the ejection fraction normal ranges on the slide stated greater than 55% is normal. Is there an upper limit that would define hyperdynamic function, i.e. sort of greater than 65-70%, say?
I don't think we quote in BSE, feel free audience to correct me if I'm wrong, but I don't think we quote an upper limit for an ejection fraction. Obviously important to note that the cavity doesn't ever empty completely, so you shouldn't be, if you've measured something and it's coming out at 80% or something, then maybe relook at your measurements because it's probably overestimated.
Perfect. And one from me, obviously people training. Would you state like a minimum logbook that you'd want people to do just for QA so that they obviously were able to do strain, or how do you do it at your hospital?
So in our centre, we encourage people whenever the image quality is good just to make strain measurements. As I say, keep the 3 traces, not just the bullseye. I can't tell you from the bullseye whether you've done a really good assessment of strain or not. So keep the 3 traces. I reckon, I don't know, maybe 30 to 50 in a logbook if you're already practiced and proficient and accredited is probably reasonable. But it's finding the patients with the image quality, she says.
I think there is some research that says about 50 cases, and I guess the point, like you say, the point is just to practice a lot. So on any patient that you can, every single time that you can. Yeah,
and not just strain, practice ejection fraction by Simpsons as well.
Yeah, absolutely. Thank you so much, Wendy.
Thank you.
Thank you. So next up, we've got Dr. Dan Augustine. So Dan is a consultant cardiologist at the Royal United Hospitals in Bath. Not only is he the co-chair of the education committee for at least another 24 hours, he is also co-author of the Oxford Handbook of Echocardiography. So please welcome Dan. Dan's going to be talking about the assessment of the right ventricle today.
Yeah, thank you very much, Evie, and thank you, Maria and Evie, for chairing this session. It's great to see so many people attending to these training track talks, which are an integral part of our conference this year. So over the next 25 minutes or so, we'll be reviewing a systematic approach to the assessment of right ventricular function. We'll discuss strengths and limitations of echocardiographic markers of RV size, function, and pressure assessment. So the right ventricle has a very complex geometry, and that's highlighted well in this slide. I'm not sure if the IT guys can just click on this video on the bottom right. Can you click? Do you mind clicking on the video? on the bottom. It should play. There we go. So it has a complex structure. So if you look at the schematic in the red box, you can broadly divide it into three sections. So you've got the inflow, where you've got the tricuspid valve and the apparatus, the infundibulum, or the right ventricular outflow tract, and the pulmonary valve and the apparatus, and then the apical trabeculated portion. And you can see how it wraps around the left ventricle. In the sagittal plane, it has a triangular shape, and in the coronal plane, it has a crescentic moon shape. And you can see it is quite a complex structure. And so by 2D echo, we're unable actually to give accurate volume or ejection fraction assessment. Yet two-dimensional echo is the mainstay of assessment of the right ventricle in terms of most of the modalities that we have. And that's why it's important that we have a unified approach to the assessment of right ventricular function. This was the BSE guidelines published a couple of years ago, and I'm sure many of you have seen this, lead author Abbas Zaidi, where Abbas and the team set about writing a guideline to show a systematic approach to assessment of right heart and right ventricular function. Many of the measurements that we make for size and function are taken from an apical view, but it's recommended that we use a right ventricular focused view rather than the standard 4-chamber view. And this is a nice paper that summarises the advantages of using a right ventricular focused view. So this group took 50 patients, referred for a clinical echo, and there were 2 sonographers, and they both measured the standard apical view and the RV focused view. So sonographer 1 would measure both views, then undertake the full transthoracic echo, and then at the end of the test, reposition the patient and undertake those 2 views again. Sonographer 2 would then come in and do the 2 views on the patient. As you can see how here they were quite nicely identified test-retest variability, as well as intra-operator and inter-operator variability. So they looked at various measures of right ventricular size and function from the standard apical 4-chamber view, shown in these red boxes, and they compared them with the RV focused view, shown in the green boxes. And they found that all right ventricular size and function parameters were significantly larger in the RV focused view. And really importantly, they also found that all markers of size and function had better reproducibility and lower variability in the RV focused view. So how do we find this view? So if we take our standard apical 4-chamber view, depending on the orientation of the probe, we'll usually be cutting somewhere between the red dashed line and the blue dashed line. And the aim is to get to the maximal basal diameter, so where the green dashed line is. So what we would do is tilt the transducer laterally, so the right ventricle and the right atrium come towards the center of the image, but we need to take care to ensure that the left ventricular apex is still at the tip of the sector. We then rotate the probe anti-clockwise, and that will bring us towards that green dashed plane, and so we'll get the maximum RV basal diameter. So if we take the 4-chamber view, tilt laterally, the RV comes to the center, rotate anti-clockwise, and that will give us our RV focus view. And a couple of things to look out for to make sure we have a proper RV focus view. So you can see the alignment of the septum, rather than being straight as it is with a standard apical 4-chamber view, is now more diagonal. And the RV free wall is now the vertical plane. And you can see that we can also appreciate the atrial septum because it's important that we avoid the coronary sinus coming in, and it's important that we avoid seeing the LVOT. So in terms of a standardized approach, I would start by looking at standard RV anatomy and a visual assessment. So from the parasternal view, we can appreciate the anterior RVOT free wall. In the inflow view, we can appreciate the inferior and anterior RV walls. And in the short axis views at the basal and mid-level, we can appreciate the inferior, lateral and anterior RV walls. And at the apex, we can appreciate the inferior and superior RV walls. And in all of these views, we should be making a qualitative visual assessment about wall motion, hyperkinesis, akinesis, dyskinesia, aneurysm presence. Sticking with the short axis view, we can also make an assessment as to whether there's any right ventricular volume or pressure overload by looking at the degree of septal flattening or the eccentricity index. So we look at a short axis view somewhere between the tips of the mitral valve and the papillary muscles, and we measure the diameter parallel to the septum and divide that by the diameter perpendicular to the septum. And if the value is greater than 1.1, then that's abnormal. So if you have increased septal flattening at end diastole, then that's indicative of right ventricular volume overload. And right ventricular pressure overload is seen with increased flattening at end systole or both end diastole and end systole. So in terms of anatomy of the right ventricular outflow tract, we've mentioned the parasternal view. We also look at the short axis view in the aortic valve level to get a proximal measurement in the RVOT1 and distal RVOT2 just prior to the pulmonary valve. From the four-chamber view, we can appreciate the right ventricular free wall, again looking for wall motion abnormality. Be cautious if mentioning wall motion abnormality around the area of insertion to the moderator band. So it's not that unusual to have small crenulations where the moderator band inserts into the RV free wall. And so I find it useful to actually stop the image and go frame by frame to see actually if that area is coming in with systole. From the standard apical four-chamber view, we get an appreciation about right ventricular volume, right ventricular size compared to the left ventricle by measuring the basal diameter. So the right ventricular diameter, if it's larger than the left, then that's abnormal, and that's a potential marker of pulmonary hypertension. From the subcostal view, we can measure the RV lateral wall for RVH. We see that in cases of pulmonary hypertension, for instance, or cardiac amyloid, and it should be less than 5 millimeters. So moving on to dimensions, and we'll start with the right ventricular outflow tract. So our first measure is in the parasternal view, end diastole. We measure from the RVOT to the junction of the ventricular septum and the AV junction. In the short axis view, the RVOT1 is made from the anterior aortic wall to the RVOT free wall, and RVOT2 just proximal to the pulmonary valve. It's really important that in the short axis views in particular, we try not to acquire an oblique image. So if we're acquiring anything that's slightly oblique, we can really overestimate or underestimate RVOT1. And RVOT2 is much more reproducible than RVOT1. From the apical view, we make our linear measurements. This is all from the RV focused view. So RVD1 is measured in the basal third of the right ventricle, the maximal diameter, and that first value for males is incorrect, so that should be 47 millimeters, not 73. RVD2 is at the level of the papillary muscles, and RVD3 is the length from apex to somewhere in line with the tricuspid valve annulus being parallel to the septum. So we've mentioned anatomical assessment in terms of wall motion, we've mentioned dimension assessment, and we'll now move on to systolic function assessment, and most of these are made from the apical window. So we'll start with fractional area change. This is an RV focus view where we measure the area at end diastole and end systole in the right ventricle. So we'll trace the endocardial border from the lateral annulus up to the apex, back down to the medial annulus. And we look at the difference between end diastole and end systole and express that as a percentage of the end diastolic area. There are some advantages. It's got good correlation with other imaging modalities in terms of cardiac MRI, for instance, in terms of ejection fraction. And there's good data on its prognostic value in diseases such as myocardial infarction, heart failure, pulmonary hypertension. Limitations of this approach is that you do need a good endocardial definition so that you can make accurate tracing. Importantly, it neglects the contribution of the right ventricular outflow tract to right ventricular volume and function, and I'll mention this later on when we talk about 3D imaging. There are two longitudinal measures that we make. The first I'd like to talk about is the peak systolic velocity using tissue Doppler at the lateral tricuspid annulus. This is simple, it's quick, it's really well validated. There are data sets of over 5,000 patients showing normality and how values vary with age. In terms of limitations, it's one region only at the base. We don't really recommend measuring this in the mid or apical cavity because usually the actual quality of the Doppler trace is poor, and also variability is high, reproducibility is low. It's angle dependent, and it tells us about the motion, it tells us about the velocity in line with the motion of the transducer rather than contraction. So it doesn't tell us much about radial function. TAPSE is made again from the RV focused view. As you all know, this is a M-mode measure through the lateral annulus. It's simple, it's quick, there's a wealth of prognostic data. This is data, one of the earlier studies showing its prognostic importance in patients with pulmonary hypertension. So they looked at TAPSE, and if it was above 1.8, then the survival at 1 year was 94%, at 2 years was 88%, and if it was impaired, then the survival was much worse, so 60% survival at 1 year and 50% at 2 years. Limitations, as with tissue Doppler, it's only one region in that basal RV wall. It's very angle dependent. It's only telling us about longitudinal motion, so nothing about radial function. It's important that when we see a failing right ventricle that's dilated, that we don't misinterpret a normal TAPSE for translational motion. And this is a good example of that in this study. So this group looked at patients with severe pulmonary hypertension due to pulmonary emboli who are undergoing pulmonary endarterectomy. So the surgeons were opening up the pulmonary arteries and removing the clots. And they measured various echocardiographic markers before treatment, before the endarterectomy and after treatment. And what they found was the TAPSE was better before the treatment, but all of the other measures improved after treatment, as you would expect. And the reason for that is that in this setting, with this ventricle, because it's dilated and impaired, and because there's volume and pressure overload, the right ventricle finds it hard to eject against that increased afterload. And so what happens in systole is that the right ventricular apex moves towards the left ventricle, and you get this rocking translational motion. If you measured the TAPSE there, you get a normal TAPSE, but if you use another method of assessment, such as fractional area change, you can see that that's impaired. So we mentioned systolic function. Moving on to a more global measure of function, and this is the right ventricular index of myocardial performance. So this is a global measure taking physiological measurements in systole and diastole. It has good clinical correlates with other imaging modalities, and also there's good data showing that it improves as diseases that affect the right heart are treated, such as pulmonary hypertension. In terms of calculating it, it's the summation of the isovolemic contraction time from systole and the relaxation time from diastole divided by the ejection time. You need good Doppler traces to get accurate signals. These are quite short time periods that we're trying to measure. In terms of IVRT, you just have to be careful if there is very high right atrial pressures. So in the setting of restrictive physiology, because the right atrial pressures are so high, the tricuspid valve is opening at an earlier stage and the IVRT is shorter. And so if you try and use this global myocardial performance here with a lower IVRT in a setting of severe diastolic dysfunction, you'll get an abnormally, reassuringly low value. There are two ways to measure it. One is with pulse wave Doppler at the tricuspid inflow and the pulmonary valve. The disadvantage of this is that they're separate views, and so you need to be careful that if you're doing separate views that you use a similar heart rate, a similar R-to-R interval. The preferred method is using tissue Doppler at the lateral annulus, and that's preferred essentially because it's one view. Wendy very nicely talked about speckle tracking, so I'm not going to go into the ins and outs of what it is and how to measure it. Just to say it represents systolic shortening, essentially, as a proportion of the original length. So it's a negative percentage value that we obtain. It's less angle dependent, it's more of a marker of global function, and it's more reproducible than tissue Doppler strain. In terms of limitations, when we're placed in the region of interest, we need to be careful, because if we place it too externally to the pericardium or too inferiorly towards the right atrium, we'll get an abnormally low value. On the opposite tact, if we have too thinner region of interest within the endocardium, the value will be above what it should be. It needs adequate frame rate of somewhere between 50 and 80 frames per second. As with most advanced imaging techniques, if you don't have good 2D image quality, you're not going to be able to produce good advanced techniques such as strain or 3D imaging. And unfortunately, inter-vendor differences in terms of algorithms still exist. There's been a whole lot of data showing the importance of RV-free wall strain in a number of different disease states, showing how it's important in assessing diseases at an earlier stage rather than traditional markers that we measure, and also in terms of prognosis. So 3D echo is our best way of assessing volumes and ejection fraction. The advantage is it's one view, it makes no geometric assumptions, and importantly, really importantly, it includes the right ventricular outflow tract contribution. So the right ventricular outflow tract contributes probably around 20% of right ventricular volumes and about 15% of stroke volume. So it's a significant player in terms of RV function. There's, again, a wealth of data in terms of correlation with MRI, ejection fraction, volumes, and also prognosis in a number of disease states. Limitations, it does need some time in terms of post-processing, but as with any technique, simple or complex, the more you do, the easier it becomes. You need good 2D windows, and we heard earlier on in the symposium, garbage in, garbage out. So if you don't have good 2D windows, you're not going to have good 3D images. Finally, and briefly in terms of function, I'll briefly mention RV diastolic function assessment. So this is not part of the standard data set. If you were going to attempt to measure RV diastolic function, there are 4 groups of measures to make. So the first is 2D morphological assessment of right atrial size and pressure and your right ventricular wall thickness. The second group is your pulse wave Doppler on the tricuspid valve, looking at your EA ratio, your deceleration time, as you would do with the mitral valve for left ventricular function, diastolic function. And you can also use continuous wave Doppler through the pulmonary valve. So in severe restrictive physiology, because of the very high right atrial pressure, you get late diastolic forward flow from the atrium that you can sometimes see on the continuous wave Doppler traces highlighted by the orange arrow. The third group is tissue Doppler assessment of the lateral annulus, looking at things like your E by E prime or your IVRT. And finally, hepatic vein assessment, looking at your Doppler flow in systole, diastole, and the normal reversals we get after systole and your atrial reversal. As with left ventricular diastolic function, no one measure should be used in isolation. So if you are going to attempt to assess right ventricular diastolic function, you need to look at measures from all of those 4 groups that I've just briefly mentioned. Finally, I just want to touch on right ventricular pressure assessment, so right ventricular systolic pressure assessment and right pulmonary artery systolic pressure assessment. So traditionally, we have used the tricuspid regurgitation jet to try and estimate pulmonary artery systolic pressure. We take a continuous wave Doppler. That allows us to measure the tricuspid regurgitation velocity. We put that into the Bernoulli equation. We add an estimate of right atrial pressure. And if you've got no obstruction to the RVOT, so no pulmonary stenosis or anything similar, then your right ventricular systolic pressure should be equivalent of your pulmonary artery systolic pressure. Normal values, 35 or 36 millimeters of mercury. However, there are inaccuracies in using this method to estimate pulmonary artery systolic pressure. You may have an eccentric jet, so the Doppler's not cutting through it. You can have a poor Doppler signal. It increases with increasing BMI and increasing age. And in cases of severe free-flow tricuspid regurgitation, if we measured the TR velocity and used that in a Bernoulli equation, that would greatly underestimate true pressures. We're then taking that inaccuracy, and when we put it into a Bernoulli equation, we're taking that inaccuracy, we're squaring it, we're then quadrupling it. So you can see how quite a small error to start with is amplified. And this is, we're a PH centre in Bath, and this is data from our centre, which Ollie Slegg, one of our physiologists, led on. So here he looked at 230 patients who had a right heart catheter and an echocardiogram within a month of each other. And he looked at the pulmonary artery systolic pressure by each modality. The right heart catheter is the gold standard to estimating pulmonary artery systolic pressure. And what we found was that the limits of agreement were very poor. So in some cases, there was a difference of 20 to 30 millimeter mercury between the right heart catheter and the echocardiogram. You may think that if there's no tricuspid regurgitation jet at all to measure, that actually a patient can't have pH, and that's definitely incorrect. And this has been shown very nicely in this registry data from the States. So this group took 1,200 patients who had a right heart catheter and an echocardiogram within 2 days of each other. And then they found that of that 1,200, 17% of that 1,200 patients had no tricuspid regurgitation measurable to calculate a TRV, but they had pulmonary hypertension, so almost 1 in 5. For this reason, international guidelines have moved away from trying to use pulmonary artery systolic pressure precisely to define the presence and severity of pulmonary hypertension, to using a probability-based approach, where you use the tricuspid regurgitation velocity in conjunction with other markers to give a probability of pH being present, either low, intermediate, or high. And these are the categories of the other markers. So there are 3 categories: the ventricles, the pulmonary artery, the inferior vena cava, and right atrium. The 2 measures in the red are new measures that were added at the most recent pH guidelines, which were released in August at the ESC conference, European Society of Cardiology. And this is the flow diagram that's recommended that we follow. So you have your tricuspid regurgitation velocity. You look for what the velocity is. You see if there are more than 2 categories of echo markers, and that will help you to define whether there's a low probability, intermediate probability, or high probability of pulmonary hypertension being present. This is work from our lab where we looked at the sensitivity and specificity of this algorithm. And what Ollie found was that the sensitivity and specificity for detecting pH was 89% and 68%, respectively. He then went on to look at each individual probability group and to see within that group what was the percentage of patients that had pH at right heart catheter. So if you had a high TTE probability of pH, around 96% of those patients had pulmonary hypertension. If you had an intermediate probability of pH, around 80% of those patients had pulmonary hypertension. What was quite striking from our data set is that if you had a low echo probability of pH, actually 35% of those patients had pulmonary hypertension at the time of right heart cath. And we have to remember there's a referral bias in all of the data that I've shown you from our site, because we're a shared care centre and colleagues from other hospitals refer people to us because they suspect people have pH. So despite a normalish echo, there's something else, scleroderma, breathlessness. And so it makes you think that actually there may be many more people that we're missing where physicians are falsely reassured by a normal echo in terms of assessing pH. We then went on to look at that low probability group to try and work out, well, are there markers that can help differentiate who has pH from who doesn't? None of the traditional markers were able to do that. TAPC, S prime, all of the things that we've talked about in terms of the traditional guidelines could do that. We looked at strain and we found that right ventricular free wall strain was significantly lower in patients with pulmonary hypertension in this low probability group than patients who did not have pulmonary hypertension. That was presented here last year, and we've gone on to do some pilot work looking at echocardiographic markers in this low and intermediate group that may improve the detection of pulmonary hypertension. And specifically, we looked at radial function, RV strain, and RV diastolic function. And we just looked at the low and intermediate probability group. If you've got a high probability of pH, the likelihood is that you have pH. So we started with these two lower groups. If your free wall strain was impaired or your fractional area change was impaired, i.e. a radial marker, we then looked at a diastolic marker and we looked at IVRT. So that if that was abnormally long and impaired, highlighting diastolic dysfunction, then we would suggest that even if your echo showed low probability, you were impulse positive and you had an increased suspicion of pH. We found that this algorithm reduced the false negatives by 29%. We found that in the low TTE probability group, the specificity was 93% and the positive predictive value was 80%. And in the intermediate group, the specificity 82% and the positive predictive value of this algorithm 86%. We've been awarded an investigator-initiated grant, so we'll be doing a prospective impulse study from next year, collaborating with Royal Free, Papworth, Sheffield and Glasgow, not just to look at the markers from impulse, but other markers as well. So, summary. In terms of right ventricular assessment and the role of echocardiography, echo undoubtedly has numerous strengths. Portable, cost-effective, good access throughout the UK, and we do have guidance on systematic approach to right ventricular assessment. Limitations in 2D echo, there are massive limitations in terms of geometry of the right ventricle, and we have limited assessment, unfortunately, in radial function, which is important in certain disease processes. We've mentioned for good 3D images, you need to have good 2D images. What's needed? I think we need to improve algorithms for diastolic function assessment, and I think we need echo markers to detect milder forms of pulmonary hypertension. The future, there is improving technology, and I think that we'll see 3D, real-time 3D right ventricular assessment becoming increasing throughout our departments, and also potentially the use of 3D strain. There's some nice papers coming out from a group in Chicago about this. We need to improve intervendor, reduce variability with regards to strain assessment, and AI, I think, will have an important part to play in some disease processes with respect to right ventricular assessment. These are the learning objectives that we've covered. A huge thanks to these guys who I work with in Bath. They're an amazing team to work with, and thank you for listening.
Thank you, Dan, for a great talk. A lot of learning points to take away there. So we haven't actually had any questions come through on Slido. So if I open up to the floor. Yes, if you want to go.
So just one thing. I don't think you mentioned it, was the RVOT acceleration time. Do you use that?
So not in terms, so we use it for in terms of pulmonary hypertension. Is that what you meant? Yes. Yeah. So that didn't differentiate between those who had PH and those who didn't in the low probability group. Yeah. But you do use it. So if you have pulmonary
If you've got a very poor TR, there's no TR.
yeah. Yes.
It's quite a good.
Oh yes. Yes. Yeah. You could. Yeah.
Dan, I wonder if we did have a question that got redacted actually, but I think it would be really important if you could go through some of the impulse findings again for us.
Yeah.
And some of the work that your group have done are in some of the abstracts this year, aren't they? So it'd be worthwhile people going down to the abstract hall and just having a read through those. But I think these are really important findings.
Yeah, so if any of you go to the Investigator of the Year session tomorrow, one of our group, James Willis, will be presenting our results on right atrial strain in terms of pulmonary hypertension. So I guess the key thing is that unfortunately with echo, we're missing people with PH. And so I think what we've tried to show is that actually there are markers that fall earlier than TAPSE. There are markers that fall earlier than tissue Doppler. And these markers with pulmonary hypertension are radial markers, diastolic markers, and the speckle tracking. And so using this, we were able to reduce those in the low, we were able to pick up a third more in the low probability group who were falsely said to not to think to have PH. And our specificity was, if you think about it, it's a low probability, so that you can't, the specificity with the BSE algorithm is very poor in that group, and ours was 93%. So I think it's encouraging early work. More needs to be done, and I'm really excited about the prospective. That's the thing. You need standardization, prospective. It's hard to do things retrospectively when you consider differences in frame rates, acquisition, angles of acquisition. You need RV focus view, etc. So we'll be able to iron all of this out in the prospective work that we'll be doing over the next 3 years.
Brilliant, thank you. There's a lot to consider in terms of RV function, but I think you're making great headway in teaching us all about what more we can do. Thank you. So our final speaker in the session, I have great pleasure to introduce, it's Emma Rees. She's an associate professor at Swansea University, and she's talking to us today about atria and the aorta. She is a registered clinical scientist with a wealth of knowledge, and I'm sure she'll be great at teaching us some new tricks today.
Thanks, Maria. I'm not sure you can see me. I can't see you, actually. So can I move this step? I'm really sure. 5 foot. Aha, there you are. Hello. I guess when I was preparing this, I thought the majority of people that came today would be trainees or novices. So the talk is aimed at that level. I make no apology for the fact that it's mainly 2D transthoracic echo, because I'm a big fan of doing the basics really, really well. So that's what I would like to get across today. These are my disclosures. You don't need to read it. There is nothing on there that presents a conflict of interest for this talk. We're asked to include this, that's why it's there. So I'd like to start with the atria and what to measure. And as other speakers have done today, just drawing your attention to this guideline, the latest British Society of Echo minimum data set. It's on the website. It's open access. There is no excuse not to have read it and to have started to think about implementing it in your department. As far as the atria are concerned, there are 3 key things that I think we need to be including in every single report that we do. The first one is a little bit contentious, and I'll talk about why in a second. So that first one is left atrial diameter. The second one is left atrium biplane volume, which hopefully you're all doing in your practice, but we'll go through that. And then the third one is right atrium area. Really importantly, we must be indexing these measures for body size, okay? So everybody should be measuring height and weight in their outpatients particularly, sometimes a bit more challenging in inpatients, but you should be measuring your height and weight in order that you can correctly categorize whether these values are normal or not. So I want to start by talking about the atria and about atrial physiology in a little bit more detail, because I think understanding the physiology, what's normal, helps us understand how disease presents when we're looking at echo. So this looks a bit complex, but it's not. It's a pressure volume loop of the left atrium. The right atrium would look really similar. And if we start with mitral valve closure, which is obviously at the start of systole, and think what's happening in the atrium. So during this phase, the atrium is acting as a reservoir. Yeah, the blood is returning to the left atrium. It's faced with a closed mitral valve. It can't go anywhere. So it's filling in. And the volume of the left atrium goes up. And the pressure goes up a bit, but not much, because this is a nice, thin, stretchy chamber. So the blue line is the atrium functioning as a reservoir. Then, when the pressure in the left atrium exceeds that in the left ventricle, the mitral valve is going to open. Yeah, the ventricle is now going to start to fill with blood. So initially in filling, you'll see this green line where the left atrium is acting as a conduit. The blood is moving through from the pulmonary vasculature through the left atrium and into the left ventricle. And then, so this is early filling of the left ventricle. And then what happens is after the P wave of the ECG, you get atrial contraction and the left atrium acts as a pump to complete that filling. And then we go back to the start again. We go round this figure of 8 loop. And the reason for pointing this out is most people understand that when the ventricle is filling with blood from the atrium and the mitral valve is open, that atrial function is very much dependent on left ventricular filling. Okay, and that's why we're interested in atrial size. So when that mitral valve's open, the flow and the pressure in the atrium is dependent on left ventricular relaxation. It's dependent on compliance, and it's also dependent on end diastolic pressure in the left ventricle. What people perhaps don't think about quite so much is that even that reservoir phase when the mitral valve is shut is dependent on left ventricular function. Because although your mitral valve is closed in systole, think about what happens to your mitral valve annular plane. Okay? That mitral valve annular plane should move base to apex, and that helps reservoir function of the left atrium. So I think it's worth looking at that in a little bit more detail, and I've put the reference on the screen so that you can look at those different phases of atrial function if you want to. The top echo here, this really shows why often we're interested in left atrial size. And it's because we're often using it as a barometer for left-sided filling pressures. That's why we're interested in it. The bigger the left atrium, often it's a marker of diastolic dysfunction. And you'll know that we use left atrial size in our algorithm for diastolic dysfunction. And this top echo is taken from an elderly patient referred with heart failure symptoms. And here, the left atrial dilatation is probably a consequence of restrictive cardiomyopathy. This is a patient who has amyloid. However, that left atrium size is really only a barometer of left ventricular fill-in if there's nothing else going on that's making it dilate. So it is important to consider, for example, other pathology that could make that left atrium dilate, and that makes diastolic function assessment a bit harder. So just be aware of that in your practice. Now, moving on to left atrial diameter, how we're going to measure this atrium. I'm old enough to remember a time when this was all we measured in the departments. We didn't have any other measures at the time. The image quality was really poor. And so we relied on this to give us a sense of whether the left atrium was normal size or not. The problem is it's a single linear measurement in the anterior-posterior dimension. I'll show you a picture of it in a second. And now we know that that's not a very good measure of left atrial size. We've got volume instead. But why do we still need it? I'd like to thank Dr. Amy Birchall, cardiologist, for pointing this out to me on Twitter. Clinicians still sometimes use these measures like left atrial diameter in risk stratification and scoring systems. So if, for example, there's a patient with hypertrophic cardiomyopathy and a clinician is trying to work out what's their risk of sudden cardiac death, they might come to this ESC risk stratification algorithm. And you can see here it asks us to enter the left atrial size measured in that parasternal long axis. So given that it's important for some clinicians, it's a good job we've got a standardised way of measuring it, right? Well, I'm not sure we have. There's a little bit of confusion here, I think, and I'd like to raise that, and hopefully we can get some clarification. This is from the latest BSE guidelines, both the diagram and the text. So the text says, measure the left atrium diameter perpendicular to the aortic root. Okay? It's at the level of the sinus of Valsalva, inner edge to inner edge, and we're going to measure it at end systole, and that's where the left atrium is biggest, isn't it? Just before that mitral valve opens. Have a look at that aortic root. To me, that's the direction that it's sitting in. And I'm not sure that that measurement in that diagram is perpendicular to that. And I think this is a potential source of confusion, isn't it? Because if you're a trainee, you want to know which way is the right way. Do you follow the diagram or do you follow the text? And this is a little bit confused further because the ASE guideline really specifically tells us that we should measure perpendicular to the back wall of the left atrium, and I think that makes sense. So, thanks to conversations on Twitter, we've raised that with British Society of Echo, and clarification is coming from Sean Robinson, who's the first author of that paper, very, very soon. What I expect will happen is that we'll hear that the diagram is correct. And that's the correct angle for measurement of the left atrium, and it's just the text, perhaps, that needs adjusting. But watch this space, so you should get clarification on that soon. So why have we moved on to left atrium volume? Why is this a much better measurement than diameter? So the Mayo Clinic looked at this a long time ago now, back in 2006. They looked at left atrial dimension, left atrial area, and left atrial volume, and they tried to work out which one had the best diagnostic accuracy, which one was the best true measure of left atrial size. The dotted line is diameter, the dashed line is area, and then the solid line is volume. Now, if you're not used to looking at these graphs, all you really need to understand is the bigger the area underneath the graph, the more accurate the measurement is. So you can see that the solid line, left atrial volume, is considered to be a more accurate measure. And that makes sense, doesn't it? You know, we're considering the length of the atrium, we're looking at the volume in two orthogonal planes, 4-chamber and 2-chamber. That makes sense to us that it would be more accurate. They also discovered that left atrial volume, when indexed to body surface area, was a really good marker of survival or cardiovascular outcomes. And then in this diagram, which shows event-free survival, you can see that people with a severely enlarged left atrium, and that's the bottom dotted line, do worse over time. So we know it's an accurate measure, and we know that it predicts cardiovascular outcomes. So we should absolutely all be including it in our reports if the images are clear enough to be able to do that. So how to do it? This is specifically aimed at the trainees who are new to echo. The first thing is you don't want your normal apical 4-chamber view necessarily. And I've tried to show why in this diagram. If you look at the picture on your left, this is a typical apical 4-chamber view. And you can see that usually we're trying to line up with a maximal left ventricular cavity size, aren't we? Left ventricle is the focus of our view. Now, in some people, the left atrium doesn't sit in the same plane as the left ventricle. So when we try and line up with a maximum size of the left ventricle, we can actually foreshorten the left atrium. And obviously that's a problem, because if I'm going to try and measure the full size of that left atrium, I'm potentially cutting off the length in this picture. So actually what you want to do is store your optimized apical 4-chamber view for your LV, as Wendy told you about earlier, focused beautifully, and then store a different loop where you're maximizing your left atrial size, okay? And I would suggest zooming on that area. Pre-processing zoom improves resolution. Post-processing often doesn't have any impact. Pre-processing zoom, really make sure you've got clear endocardial definition, and you want to make that left atrium look as long as possible, okay? That's one of the keys here. So you'll do it in your 4-chamber view, and then you're going to repeat it in your 2-chamber view, and that will give you your biplane measurement. So the take-home message, dedicated view of left atrial size for measurement. I'm sure I don't really need to run through this because it's quite self-evident from the guidelines, but you scroll to end systole immediately before mitral valve opening, trace around the annulus from one side to the other. It doesn't really matter which side you start. The key thing is to avoid the pulmonary vein openings in the four-chamber and avoid the left atrial appendage in the two-chamber. Just make sure that you don't include those. Here are my extra tips for accuracy. And not many people do the first one. So what should be happening is if I don't foreshorten my left atrium as I rotate from four-chamber to two-chamber, my atrium should stay the same length, okay? What you do when you're a trainee is as you rotate the probe, you slip a bit, okay? And that can mean that you foreshorten the apical two-chamber. So a tip is check that the length of the atrium in both views is within 5 millimeters of each other, because it should be, all right? If not, think, have I slipped? Do I need to go back and get that view again? The other thing is probably more related to some of the analysis software. So there's one particular software I've noticed that when you trace around and it splits up your left atrium body into discs, sometimes you get gaps, okay? Diagonal gaps at the corners. And what that means is those bits aren't included in your left atrial volume measurement. So check your analysis software and make sure that when you've traced around, every bit of that left atrium body is covered by those discs. And the last tip is that you should be using the method of discs. Sometimes your echo machines will give you a choice of two methods of getting LA volume: the area length method and the method of discs. These two are not interchangeable, okay? The area length method overestimates compared with method of discs. So BSE recommends method of discs. I think if you're not using that in your department and you're using area length, just make sure everyone is using area length, because obviously we do repeated studies on people and we want to make sure that any changes in size are not due to our measurement difference. So moving on, you've got the measurement. What do you do with it? A word on reference ranges, okay? Obviously, what we're trying to do with that number is we're trying to differentiate patients who are free from disease with those who have disease. But that's not as straightforward as we sometimes think it is when we're learning about scans. Because, for example, left atrial volume will exist over a wide range of numbers in the normal population. And actually, the population with disease, their ranges of measurement will overlap with that normal range. So it can be quite tricky. So when the BSE folk are trying to establish the reference ranges for our posters that we use in our department, they take a particular approach. And for the latest guidelines, they use the Norris study, which you've heard talked about in some of the other talks. So this was a multi-center study in Europe, about 700 patients included, and the echo measures were all done in EACVI accredited labs, in core labs. So it's quite robust data. And the way they decided what a normal value is they take the mean from the population, from a healthy population, and then they look 2 standard deviations beyond that, because 95% of the normal population should fall within that range. So if somebody falls outside of that reference range, we can be more confident that they might have disease. Of course, they might not. They might just have a big normal left atrium. What I would recommend you do, because I've watched this tutorial and it's really good, is to go to the BSE website, particularly if you're a trainee, and look at them talking about how those reference intervals came about. Because also in that tutorial, they discussed their rationale for some of the cut-off limits. And sometimes that wasn't an easy decision to make. So I would recommend you go to that. Back to our left atrium. We're indexing our volume. The decision making is quite straightforward. Is it normal? is it dilated or is it somewhere in between? Okay, and I would firmly recommend that you use this terminology in your reports. Okay, normal, dilated, or borderline. So, moving on to right atrium. I'm not going to go through all of those concepts for right atrium and aorta as well, because we've gone through them now. I'm just going to rattle through the measurement bit with some tips of how to do the measurement well. So, right atrium area. As Dan has said already, you really need to get your right heart assessment done in an RV-focused view. My tip there would be for you, if you're a trainee, often you don't need to move the probe where it is on the chest. I don't know if anyone's talked to you about heel-toe rocking of the probe, okay? But sometimes when we say, oh, angle more this way, it's hard to understand what that means. But sometimes if someone says, just put a bit more weight on the heel of the probe or the toe of the probe, it helps you understand which way to tip it. So here what you need is more weight on the heel of the probe, so you're angling a bit more medially in the patient's chest. In some people, you do need to slide a bit more laterally, but not in everybody. It's sometimes just that small movement. I won't go through how you identify it's an RV-focused view because Dan has done that already. A key thing is to make sure that you do that little bit of rotation to make sure you've got the width, the true width of the right heart in there. And then optimize the endocardial border definition. I would zoom, change your focus position, and then store that loop for measurement of area. Okay, so this is an example of a right atrial area measurement. We're just tracing round from one side of the annulus to the other. And again, it's done immediately before that valve opens, immediately before tricuspid valve opens, because that's when the right atrium is at its fullest. So this person's right atrium, this was the person I showed you with amyloid earlier. This person's right atrium is 43 centimetres squared. What you should be asking yourself is, how big is the patient? Okay, because you need to index that to the patient's size. So this is the normal, the reference range. So if it's less than or equal to 11 centimetres per metre squared, then it's within the reference range, and anything above that is abnormal. Okay, so it's pretty straightforward. You'll notice the values aren't different for males and females if you index it for body surface area, okay? Because the relationship with body surface area is more important than the relationship with gender, and that comes from the Norway study as well. One of the interesting things about this is that in the Norway study, they actually don't use an RV-focused view for their right atrial assessment. So it's probably worth finding out from the BSE tutorial why they decided to do that for their reference range. Now then, this is a bit of a bugbear of mine, and I'm not sure everybody feels the same way. Perhaps they don't. But I see a lot of patients, a lot of sonographers who move on from looking at RA size, trying to estimate right atrial pressure using the IVC. A lot of intensivists will tell you, not sure about this, not sure about how good this is or how accurate this is, but we do it, and it's part of our standard data set. I'm not a fan of doing it with M mode. So in the middle, I've shown you an M mode of a patient, and it shows you that the maximum diameter of the IVC is 3.4, which is big, and then the minimum diameter on the M mode is 1.5. And that suggests to us it's a big IVC, but it collapses by more than 50%. And that allows us to estimate an intermediate right atrial pressure, potentially. What I want you to do now is have a look at the image from which that was drawn, the loop, which is on your left-hand side. Have a look what happens to that IVC when the patient sniffs. Can you see that it moves completely out of the plane of where the cursor is? And that's where I'm taking the M mode from. You can make your patient look like the IVC is collapsing, even if it's not, or if you move the probe a little bit. So my advice to you would be to measure those dimensions from the 2D pictures, and in this case, the collapse was actually only 25%, showing that the patient's right atrial pressure was actually very high. And again, this was the amyloid patient. Okay, so the tip there would be IVC assessment on 2D. Have a look at it on M mode if you like, but just be aware of the pitfall in that measurement. And then finally, moving on to the aorta. 3 measurements to do in most people, but I would say you perhaps need to add some if the aorta is dilated. So sinus of Valsalva diameter, sinotubular junction, and then proximal ascending aorta. Here's the important thing in the latest guidelines. They are not indexed for body surface area, they are indexed for height. Really important in your departments that you check whether your reporting software has been updated to reflect those latest guidelines. None of us have got time to be indexing things manually when we're reporting, have we? So make sure that your department guidelines are modified for that. Some tips, because people struggle sometimes to get the ascending aorta in the picture. So when you're imaging the aorta in the parasternal long axis view, the standard image is on the left. If you move your probe a little bit closer to the sternum, or if you're struggling, go a rib space a little bit higher, you can often see that tubular section of the proximal ascending aorta more clearly. If you can't see it there, but you think it's dilated, you could also try a right parasternal view, where you get the patient on their right-hand side. So maybe look that up. I've not put an example of that in here, but maybe look that up if you feel like that might be of value to you. So you're going to optimize your aortic wall here, because that's what we're going to measure. Zoom, because we're measuring quite a small dimension, and then store. Oh, I forgot to say, that video, 123 Sonography, is the website that it's come from. Really good educational resource for trainees. Okay, so feel free to go to that. So measuring the aorta. Most of the measurements are done at end diastole when the aortic valve is shut. Okay, so this is actually from the ASE guidelines, because I prefer the diagram, but the principle is exactly the same. You can see number 2 is your the maximum diameter of the aortic root at sinuses of Valsalva. Number 3 is the sinotubular junction. And then number 4 is the proximal ascending aorta. In the new guidelines, what the recommendation is that proximal ascending aorta is 1 centimetre measured from the sinotubular junction. The only thing that I would say about that is it depends on where the ascending aorta is dilated. I want to measure it where it's at its maximum, but if you're doing the scan after me in 6 months' time, how do you know where I made that measurement from? So what you do is you make your measurement at the widest point, and then you measure back from there to the aortic valve annulus, where number 1 was. And then you can say in your report, the widest diameter was 3 centimetres, measured 3 centimetres from the aortic annulus, and then the person after you knows exactly where it was widest. How am I doing for time, Maria? Fab. So, for the BSE guidelines, we're going to measure inner edge to inner edge. Different from the ASE guidelines, but it makes very little clinical difference to the measurement, okay? And actually, when you think about it, measuring leading edge to leading edge feels a bit nonsensical. Why do you want to put the aortic wall into a lumen diameter measurement, particularly when that aortic wall could be calcified and thickened with aortic plaque? Doesn't make any sense, but it doesn't make any difference really clinically. So go with inner edge to inner edge. Why are we interested in the aortic diameter? Well, it's because the valve sits in it. And often, when we've got aortic regurgitation, we're having to think about the mechanism for that aortic regurgitation. It is often that there is dilatation of that aortic root. And it's actually, we use that aortic picture in our Carpentier classification of aortic regurgitation. So it is a really important thing to have in there. One thing to point out is if you're measuring the annulus of the aortic valve, that is not done at end diastole. It is done in mid-systole, okay? So make sure you do that at the right point in time. I've mentioned about the widest diameter. So reporting the measurement. Now, there are slightly different values for males and females, but they're like a millimetre difference. So they're not massively, it's not hard to remember what those guidelines are. And remember that it's indexing for height, not body surface area. And then finally about the aorta, just to encourage you to not forget about the other views that you can see the aorta in. Okay? Actually in the parasternal long axis view, don't forget that you can see the descending thoracic aorta behind your standard parasternal long axis view, okay, behind your left atrium. Sometimes you can see that it's dilated there. You could have a right parasternal view, but you should be doing a suprasternal view in everyone, okay? So get familiar with that. In your apical two-chamber view, with a little bit of angulation, you can bring in the descending thoracic aorta. And then don't forget that in your subcostal view, and you should be doing that in everyone, you can see the abdominal aorta. All you need to do is rotate your index marker to 12 o'clock and you'll get it as a nice long tube. I would do these measurements in everyone. I have a look at them in everyone and have picked up some undiagnosed aortic aneurysms, abdominal aortic aneurysms. So it's a quick thing to add to your scan if you can. And then the last slide, just a look into what the future might hold. I mentioned at the start about the atria having phasic function, and there's quite a lot of interest now in what do those different phases of atrial function potentially tell us. I would encourage you, I'm not going to talk about it because I'm not an expert on this at all. I would encourage you to look at this state-of-the-art paper that was published in JACC in 2019, which looks at the rationale for 3D quantification, strain in the left atrium, etc., all of the different phases of function, if you're interested in that. And I'm looking forward to hearing what's in the new strain guidelines, because it'll be interesting to see what's in there from the left atrium. That's it. If you want to contact me, some trainees are shy to speak during conference. I was always painfully shy. You can come and say hello in the break if you like. I don't mind if you want to do that. Or you can contact me on Twitter or by my email address. Thank you.
Thanks, Emma. It was an amazing practical overview of how we can do those measurements. So thank you. I think we've got a couple of questions come in.
So one of the first ones is, do you routinely measure and use left atrial area as part of your assessment? Would you ever use that in any situation?
I don't. I know there are people that do. Where I am aware of it being measured, it was a sort of interim step between left atrial diameter and volume. And now that we have volume, I think we all appreciate that that's a more accurate measure. So I would go for that.
And the last one really, Emma, was about indexing and whether you think indexing the atria for body surface area is an issue when a patient is obese. And what would you do in that situation?
There's quite a lot published on this. Whether there are better ways of indexing that don't depend on a particular relationship between body size and left atrial size, I think there are issues, both in overcorrection and whatnot. But I think it's the best we have for now until we have a stronger evidence base to say otherwise. But there are groups publishing on, raising measures of body size to a particular power, looking at allometric scaling of the atria. So it might change in the future. But for now, let's all do the same thing.
Brilliant. Thank you so much. And thank you to all of our speakers because it was a brilliant session.